briefly, I would like to first outline in the view which I will be presenting. First, we will discuss about basic pathophysiology, then diagnosis, then basic medical and intensive treatment. Then we will focus, we will shift our focus on towards the surgical aspects of treatment. So, starting with the presentation. So, what is a spontaneous intracerebral hematoma? It is defined as an acute and spontaneous bleeding within the brain parenchyma that may extend either into the ventricles or into the subarachnoid space as well. Most common sites of spontaneous IgH are generally the deep brain structure, such as basal ganglia and thalamus, and hypertension and old age associated amyloid angiopathies represent the two primary main risk factors of primary intracerebral hemorrhages. So, coming to the epidemiologies, it is fairly common. Incidence is almost 12 to 15 cases per 1 lakh population, and hypertensive strokes accounts for approximately 10 to 15% of all stroke cases. According to recent statistics by WHO, by 2025, almost 1.5 billion patients or 1.5 billion population in the whole world would be hypertensive. So we can easily say that this is going to be a big issue and big epidemic issue in the future as well. So, as we all know, hypertension is the most common cause for intracerebral spontaneous ICH. There can be non-hypertensive causes as well, like AVMs, aneurysms, hemangiomas. It can also be associated with bleeding disorders or anticoagulant use and other causes just as tumor, amyloid angiopathy, and other psychosomatic drug use as well. So hypertension is the single greatest modifiable risk factor for these patients. Diabetes with hypertension also works as the risk factor. Anticoagulant treatment also predisposes the patients for hypertensive bleeds. And as we all know, chronic kidney disease is a state of coagulopathy. So there's a chance of spontaneous intracerebral hematomas in kidney diseases as well. So what happens inside the brain? What is the mechanism of brain injury that patient develops symptoms? So the mechanism responsible for brain injury is multifactorial and complex. It can also primarily it is due to the primary effects of blood into the brain and hemoglobin breakdown and its products. So primarily it is due to the direct effect of acute hemorrhage that cause disruption and mass effect, localized mass effect and into the cerebral tissue. And if hematoma continues to expand in the first 24 hours, that can lead to secondary injury, which may cause increased ICP, herniation syndromes, or hydrocephalus. So initially 6 hours is the time of primary injury that is due to toxicity of blood products, local inflammation, or localized cerebral edema. If hematoma expansion occurs and the raised ICP occurs after 6 hours, that may contribute to secondary injury that causes increased ICP, hydrocephalus, and brain herniation syndromes as well. So, what is happening inside the arterioles where these processes are happening? So, in hypertension, long-standing hypertension, there is degeneration and fragmentation and fibrinoid necrosis going on in the small perforating arteries. There is a formation of segmental lipohyalurosis in the arterioles that can cause that causes a false aneurysm kind of picture, which is named after Charcot and Bouchard. So these weakened arterioles are predisposed to effects of hypertension, and they, because of their inherent weakness, the patient is predisposed to these bleeds and hemorrhages. Sometimes the etiology also determines the location of hemorrhages. Amyloid angiopathy associated bleeds are most likely, or almost of all of the time, are lobar in nature. But the bleeds associated with hypertension leading to arteriosclerosis are generally supratentorial deep bleeds. Just sites would be basal ganglion and thalamic bleeds are caused by these things. So how does these patients present? The classic presentation, as we all know, can be sudden onset of focal neurological deficit, which is associated with headache, nausea, and vomiting. Seizures also can occur, and in infratentorial hemorrhages or posterior fossa hematomas, we can also see signs of brainstem dysfunction, cranial nerve abnormalities, ataxia, and nystagmus. So the patient has come, and we are suspecting to be a case of hypertensive stroke. So a brief history taking into consideration of all the symptoms and signs and other holistic approach should be taken for. We should look upon the time of symptom onset, the symptoms of the patient, any vascular risk factors associated with patients like hypertension, hyperlipidemia, diabetes mellitus, any medications, history related to medications like antithrombotic use, anticoagulant use, OCP use, any substance use should be also taken into consideration, and systemic diseases like malignancy, liver diseases, and hematological disorder should be in our mind in initial assessment of the patient. So before coming into the management part of thing, I would like to briefly show the level of recommendations that we will be using upon in further course of this presentation, that are the mainstay for the guidelines for the management of these patients. So class 1 recommendation means a response for beneficial strong beneficial response for the recommendations. Class 2A means a moderate beneficial response. Benefit is greater than risk. Class 2B is a weak positive response for a certain procedure or medicines. Means the benefit is slightly greater than the risk. Class 3 means there's no benefit with the stated response or treatment. And class 4 means there's a negative influence or negative outcome related to that intervention. So the patient has come, we are suspecting the intracerebral hematoma or hypertensive stroke. Initial history has been taken. We would like to first do a rapid CT and MRI if available to confirm the diagnosis of any hypertensive stroke. CT angiography in these settings are not routinely done, but if we can find on a plain CT an atypical bleed, then if it is available, then it can also be done to rule out any atypical causes of bleeding. And after the initial diagnosis has been done, there is also a role of serial head CT scan in cases where hematoma expansion is suspected, or there is a there is a patient which are having low GCS score, and their patient is having neurological deterioration, which so that we can evaluate for hematoma expansion, hydrocephalus, or impending herniation. And additional to that, in CT scan also, there are specific signs that can be predict in future impending hematoma expansion. Just for example, in non-contrast CT scan, if irregularities at the hematoma margins are present, we can predict that this patient might land up with in repeat CT scan a larger volume of hematoma. And there's a spot sign on CT angiography that also is a sign of contrast extravasation in the bleed. That can also be a predictor for hematoma expansion. So the diagnosis has been made, CT scan has been done. So the primary treatment should be started. Appropriate life-sustaining therapies, the primary ABCs of any critical patient should be done first. After airway, breathing, and circulation is is restored and taken care of, ideally the patient should be transferred to a specialized unit with a multidisciplinary team. If any specialized unit is not available, then it is feasible to transfer the patient with with in such a facility where full range of high expertise and care is available. So, what are the guidelines for blood pressure monitoring in this patient? No, now the primary treatment has been done. Patient has been transferred to a well-equipped facility. The goal of BP treatment is very important. The goal should be smooth and sustained control of BP, avoiding large variability, peaks, and large variability in the systolic BP. It is beneficial to maintain a smooth and sustained control of BP. Ideally, treatment should be started within 2 hours of ICH onset, and the desired target should be met within 1 hour. If patient presents with moderate to severe size of ICH and systolic BP between 150 to 220 millimeter of mercury, lowering of systolic BP to a target of 140 millimeter of mercury with goal of maintaining the range of 130 to 150 millimeter of mercury is a safe and reasonable approach. There's a class 2B recommendation regarding this. The ideal range of these patients should be in the range of within 130 to 150 millimeter of mercury. And acute lowering of systolic BP to less than 130 millimeter of mercury is actually counterintuitive and potentially harmful. That has been shown in various trials. So that is a very practical, I think, practical guideline, because in our practice, many times patients' relatives tend to say that BP is around 150, it's not getting normal. So we should not be very get carried away with that thing. And the ideal BP should not be too low. It should be around in the range of 130 to 150 millimeter of mercury. Moving on with the general care, hyperglycemia and hypoglycemia should be avoided. Both hyperglycemia and hypoglycemia are detrimental for brain, and it can hamper with the outcome of the patients. Temperature, likewise with the fever and temperature management, pharmacological treatment of high fever is reasonable to improve functional outcomes. There's a class 2B recommendation regarding this. And if temperature fluctuate too much temperature fluctuation also is associated with poorer outcome in these patients. And the usefulness of therapeutic hypothermia, that is less than 35 degrees centigrade, to decrease peri-ICH edema is still unclear. So there's not clear guidelines regarding the use of hypothermia in these patients. Likewise, if the patient presents with seizures and any suspicion of seizure is there, there's a class 1 recommendation regarding administration of anti-epileptic drugs. But if the patient does not present without any signs of seizures, there's a there's a recommendation regarding avoiding anti-seizure drugs. It doesn't show any benefit. But in our practice, we generally give anti-epileptic medicines to generally all the patients, because seizures can also, if it is not present at initial onset, it can present later on. It can complicate things in many setups. Coming to neuroinvasive monitoring in these patients, if patient presents in initial CT scan with IVH with hydrocephalus, which is leading to decreased level of consciousness, ideally ventricular drainage should be performed. It may reduce mortality. ICP monitoring is recommended to reduce mortality and improve outcomes. But ICP monitoring is sometimes very not possible in many centers in our practice also. Hyperosmolar therapy is considered for reducing ICP. The class 2B recommendation is there. It is beneficial regarding use of mannitol. And importantly, steroids should not be administered for treatment of elevated ICPs in spontaneous ICS. No benefits have been found. In many peripheral centers, we will see that steroids are administered without thinking, without giving any thoughts. These should be avoided. So, these were the basic medicinal points or general management regarding these patients. Now, before coming towards the surgical aspects, what what is the rationale or logic behind the surgery? What is the thoughts behind surgery? We all know that majority of ICH patients do not require surgery, these patients. But what is the hypothesis or what is the logic behind removal of an intraparenchymal hematoma? This logic is based on the assumption that the clot removal would restore the normal cerebral architecture. It will reduce the mass effect. It will correct or avoid impending midline shift. So it would improve cerebral perfusion by decreasing intracranial pressure. But leaving theory aside, the surgical removal of a blood clot within the brain is not free of risk. In order to reach deep structures, a large layer of healthy tissue needs to be dissected, and it can cause large layer of healthy cerebral tissue needs to be dissected, and it may cause cortical injury as well. Additionally, any post-surgical complications such as hemorrhages and infections are also not common in these settings. So what are basic surgical options in these patients? There are basically four options in these patients. Either we can go ahead with craniotomy and do hematoma drainage. If patient presents with intraventricular hemorrhage, then insertion of EVD for intraventricular hemorrhage management as well as side by side ICP monitoring can be done. Third option is decompressive craniotomy with hematoma evacuation or without hematoma evacuation. And the four and the most recent ones are use of minimally invasive approaches. So we will be discussing one by one all these approaches. So first we would be discussing regarding the use of craniotomy for supratentorial hemorrhage drainage. So it is the most common strategy applied in most centers, and it is also the most studied approach so far. First study related to the use of craniotomy in these cases was done way back in 1960s when Matt Kissock and colleagues did a trial of 180 patients where they compared results for craniotomy with versus conservative treatment in these patients. They were at that time were unable to demonstrate any benefit from surgery in regard either to mortality or morbidity. The most well-known trial, Stitch trial, it was the first well-powered, multi-centered, multinational RCT which compared the benefits of early hematoma drainage with initial conservative treatment. It was done in 2005. The studies were published in Lancet in 2005. It had inclusion criteria. It is the one of the most quoted trial in these cases. It had inclusion criteria of a patient with diagnosed case on radiography of a spontaneous ICH. A hematoma diameter greater than 2 centimeter was taken and GCS of more than equal than 5 was taken as inclusion criteria. Exclusion criteria were in this trial were hemorrhage due to any other vascular abnormalities, hemorrhage due to tumor, posterior fossa hemorrhage was excluded in these patients. And if surgery was not performed within 24 hours, these patients were also not included in this trial. And outcome was determined on extended Glasgow outcome scale, which is which as you can see on the figure, which graded from 1 to 5 in good outcome, moderate disability, severe disability, vegetative, and expired stages. So after stitch trial one was was going on, while they were doing stitch one trial, they they divided many patients into many subgroups according to age, hematoma volume, GCS, hemorrhage location, and the depth from the cortical surface. So while they were investigating, they found there is a sign of possible benefit in a subgroup of patients with superficial hematomas 1 centimeter or less from cortical surface or lobar hematomas. So a second study was performed by the same group of investigators to test this hypothesis that superficial hematomas within 1 centimeter from cortical surface or lobar hematomas, they might benefit from early hematoma removal. So stage 2 trial was done in these patients. So after conducting stage 1 and stage 2 trials, what the investigators found, they concluded that surgical surgical option did not show any functional or mortality benefit with early hematoma evacuation. They concluded that early craniotomy for hematoma evacuation cannot be recommended as routine care for patients suffering from supratentorial ICH, especially in deep hemorrhage, and also in small lobar hemorrhages with preserved level of consciousness. However, craniotomy for hematoma drainage can be considered as an important life-saving measure in critical situations, such as large hematoma with mass effect and midline shift. So briefly, in this chart, these recommendations are written. Craniotomy for hemorrhage evacuation to improve mortality or functional outcome is of uncertain usefulness. But craniotomy for hemorrhage evacuation may be considered as a life-saving measures in patients who are deteriorating. These were the conclusions from stitch trials. So basically, what they did was it can be chosen as a life-saving measures, but any functional or long-term outcome will be there or not, they were not able to prove. In contrast to supratentorial ICH, surgical treatment of posterior fossa hemorrhages have better clear-cut guidelines and clear-cut results. Available management strategies in these patients are either suboccipital decompressive craniotomy or EVD insertion. And these procedures are studied. There's no RCT done yet in posterior fossa hemorrhages. All these recommendations are based on class 3 studies only. These studies have suggested that cerebellar hemorrhage greater than 3 centimeter in diameter or 15 cc in volume, causing brainstem compression or causing acute hydrocephalus may be better managed with early surgery. So there's a clear-cut recommendation in cerebellar hemorrhages that if volume is great, diameter is great, patient is having hydrocephalus, patient is having brainstem compression, go for surgery as soon as possible. Even in cerebellar bleed, if preserved level of consciousness is there, GCS is around 14 or 15, diameter of hematoma is less than 3 centimeter or less than 15 cc, conservative treatment trial should be done. That is summarized in this chart as well. If cerebellar ICH presents with neurological deterioration, brainstem compression, obstructive hydrocephalus, immediate surgical removal is the standard, plus with or without EVD. Now coming to specific patients who are in coma, GCS score is less than 8, large hematomas, patients having refractory intracranial pressure, refractory increase of intracranial pressure. In these patients, decompressive craniotomy with or without hematoma evacuation may have a role in reducing mortality of patients, but still available evidence of decompressive craniotomy is based only on class 3 studies. So to summarize, in critical patients having large hematomas, significant midline shift, elevated refractory ICP, decompressive craniotomy may be considered only to reduce mortality, but decompressive craniotomy to improve functional outcome is still the outcome is uncertain. Now we have covered supratentorial bleeds, infratentorial bleeds. Now coming for shifting our focus on intraventricular hemorrhage management. So intraventricular hemorrhage is dangerous in the sense that it can interrupt with the normal flow of CSF, which may cause acute hydrocephalus. If the patient develops hydrocephalus due to IVH, it requires urgent placement of an EVD, which which allows for CSF drainage as well as ICP monitoring also. There was a specific trial conducted in 2011, which named CLEAR trial, which compared the use of low intraventricular dose of recombinant RTPA tissue plasminogen activator and insertion of EVD, and they compared 6-month functional outcome with placebo. They were not able to find any functional outcome benefit with EVD or even with installation of RTPA in these patients. So, if the patient presents with spontaneous IVH with obstructed hydrocephalus, EVD can be considered as an option for mortality reduction. Functional outcome benefit is still not clear. EVD can EVD sometimes endoscopy and EVD with thrombolysis is also been tried, but still functional outcome benefit is not too clear. And if the patient will further depend on shunt, that is also cannot be avoided. It means placement of EVD does not guarantee the patient will not need shunt in the future. Now coming to the minimally invasive surgical approaches for ICH. So these are the latest approaches in which an endoscope measuring approximate 5 to 8 mm in diameter is introduced through a burr hole created in the skull. There was also a trial associated with this, which was MYSTERY trial, which full form of which would be minimal invasive catheter evacuation followed by thrombolysis. However, compared to open surgery, minimal invasive technique seems to be safe, efficacious, and reproducible. But recent data from randomized trials also did not show any significant benefit of this technique when compared with conservative treatment. So, if supratentorial bleed patient comes, hematoma volume is more than 30 ml, 20 to 30 ml, GCS is around 5 to 12, we can consider for minimal invasive surgeries with hematoma thrombolysis to improve mortality. But these approaches, either open or minimal invasive approaches, to improve functional outcome, it is still uncertain use. However, choosing minimal invasive approach rather than craniotomy to improve functional outcome may be a better reasonable approach because it has lower infection related complication and there is less normal brain dissection associated with these approach. So, why have all surgical ICS trials might have failed in the past? That is a very interesting point because there are many trials have been conducted. Why all those are not showing any benefit in these patients? There might be a reason behind this, that the primary effect of hemorrhage that has injured the brain, it is a possibility that it cannot be reversed with surgery. The primary impact that has caused the injuries, the initial effect of blood and toxin products that has caused that damage, is may it is a possibility that it is not be reversed with surgeries. And in these trials, there were large crossovers from medical management to surgical group also. And ideal candidates and optimal timing of surgery, these were the essential questions that have not been categorically determined in these trials. And especially in neurosurgical patients who require urgent procedures, recruitment to these trials are also difficult. There were also problems with study designs, sample size, and number of excluded patients also. So, what are the current guidelines by American Heart Association or European Stroke Association? Majority of patients with spontaneous supratentorial ICH, benefits of surgical evacuation is not well established, with no supporting evidence for routine surgeries. However, surgery can be used as a life-saving measures in patients with neurological deterioration or in patients with persistent low GCS score between 9 to 12. Coming to decompressive craniotomy, it can reduce mortality, especially in those in coma with large hematomas. But any functional outcome benefits, it is still not clear. However, in patients with posterior fossa hemorrhage, there is certain class 1 level of evidence that acute hydrocephalus, brainstem compression, or worsening in neurostasis, surgery should be performed as soon as possible. So, to conclude, uh, as we all know, role of open craniotomy for early hematoma drainage after intracranial hemorrhage, it's a topic of is a huge debate. But randomized control trials in the past have failed to demonstrate its benefit in either in terms of mortality or functional outcome. So caution needs to be exercised when interpreting these results because patients who were considered to benefit from surgery were also excluded from these trials as well. Craniotomy can be considered for hematoma drainage as a life-saving measures in critical situation. And I will and need of the future would be, I think, a fair specific trial should be done in these patients regarding the use of surgery, and unnecessary surgeries in spontaneous ICH, which can be managed conservatively, should be avoided. And decision to operate should be taken in a holistic way, taking into consideration the socio-economic status of the patients, the current neurological status of the patients, because down the line, after 1 to 3 months, we don't want a patient permanently in the vegetative state, being a burden on the family. These things should be done. And I suppose in the future, some trials will be done which will give a clear recommendation regarding the use of surgery, as there are in traumatic brain injuries as well, like associated with motor response or dominant hemisphere bleed, non-dominant hemisphere bleed. The trial are the need of the hour. So, by this thing, I would like to conclude my presentation. Uh, and again, thank you everyone for their patient listening, and thank you everyone for giving me this opportunity on this platform as well. Thank you.
Thank you, Anindya. I think you have summarized very well about the various controversies and whatever the accepted management strategies. I think we have a lot of neurophysicians also in this group, and many of you are in government setup or private setup. They are facing so many patients. of intracranial bleed. So I want to hear the practical aspects of management of ICH at your centers or your opinions. Dr. Praveen Sharma, are you there?
Hello.
Dr. Rajesh Verma?
Hello.
Yes. Uh, Anindya, can you stop sharing your
Yes, sir.
slide
Yes, sir. Also.
so that we can see the people?
Sure, sir. Yes.
Yeah. हेलो कनकनी साहब कहाँ रह गए थे आप?
Sir, there was some technical problem in my in connection. So I'm here. So I welcome you all on behalf of UP UK Neuroscience Society.
Thank
And
you,
it's
thank you.
a welcome step from all of you. I'm thankful to Anindya who accepted my proposal of delivering lecture on stroke and intracranial bleed. She has delivered very nicely. I joined late, but I have listened his well-remarked comments. It is also, I think, useful for neurophysicians also when to refer the patient for surgery and when not to refer the patient for surgery. So I think I hand over to again Dr. Rajiv Agrawal for next talk. We have few questions in our chat box. We'll take it after the second talk. One question is there, I think, from the Naresh Kishnani, who is asking: is endoscopic evacuation, can hemostasis be done effectively? So, what is your
Anindya?
comment about this?
So, question to me.
Yeah,
Yes,
Anand,
it is
it's to
to
you.
you.
Yeah, endoscopic evacuation, hemostasis is an issue, but by continuous irrigation of saline, it can be achieved, but still, we are not, compared to microscope, we cannot be very sure that the complete hemostasis has been done or not. Endoscopy has a benefit in compared to open surgeries in a way that it's a little less invasive. These are the main benefits. Hemostasis is an issue in endoscopic surgery, that I can agree upon that for sure. I would like to take Dr. Rajiv Agrawal's opinion as well, what he thinks.
I don't think so. I have any personal experience regarding this endoscopic evacuation of ICH, but whatever I have read about it, like it's you tend not to remove a hematoma completely, so that not to disrupt the layers of the normal brain parenchyma, which usually acts as a barrier and prevent rebleeds. That is one thing. Aggressive removal of hematoma. Your primary aim is to decompress the brain rather than to take out the hematoma as completely. Using a thrombolytic agent in endoscopy is that's why considered a little bit risky also, because that leads to additional risk of rebleeds. Oja sir will comment better.
No, I have seen people removing large hematomas through endoscopic route without much problem in hemostasis. Of course, most of the time there will be some residual hematoma in post-op CT scan. As Rajiv said, that most of the time there is significant reduction in the mass effect after removal, but you need not to worry about a small blood that you may not have removed or that has been left in the cavity. Of course, everything is very controversial. That is why I wanted that even neurophysicians should give their opinion.
Sir, actually, we are teaching lot of this stroke patient of hemorrhage also, and as per my experience for in last 15 years, we have seen that in the deep hematomas, I think surgery is not required, and in which surgery has been done, the results has been not good. The only things where the surgery may be indicated is the posterior fossa bleeds and some cortical large bleeds where surgery is beneficial. Otherwise, in most of the cases, it is not beneficial, and especially in the basal ganglia and other hypertensive bleed. Second, my comment is on regarding the starting of anti-epileptic. in actually good setup, in medical college setup, it should not be started, because once it has been started without seizures, then how long we should continue, and that is great controversy regarding that. So we should observe this patient, and if seizures occur, then only we should start. Otherwise, the anti-epileptic should not be started. Third, regarding use of antihypertensive, Dr. Gupta has very well said that they should not be BP should not be dropped down acutely, but regarding a hypertensive bleed, it should be around 120, 130, not more than that. So we have to reduce the blood pressure, but it should not go below 120, but it should be around 120, 130 systolic. So these are my experiences which I want to share. But the only thing that the craniotomy may be helpful in some patient to as a decompressive therapy. And evacuation of hematoma is how much beneficial we can't say.
So may I give my comment on this, if I am allowed?
Yes, yes, sure, sir.
What is happening
sir.
in various hospitals, I mean, especially large hospital with this sort of corporate backup. So most of the bleed patients, they are admitted under neurosurgeons, and only 10% of them, they require surgery. So one of the most important factors why patient should be treated under a medical department is control of blood pressure. It's still controversial, but latest few trials, couple of years back, have shown it has to be judicially lowered down within 1 hour of the presentation of the patient to the ER and the hospital. If it does not happen, that is the one most important factor which leads to expansion of the hematoma. Then surgery would be, I mean, required just to make a person disabled for the whole life or just to save the life. So at least hypertensive bleeds, they should be managed by combined team approach of neurophysicians, and if required, neurosurgeons have to be called into the picture.
I just want to summarize overall my experience. Most of the time, it is the volume, the hematoma, which pressurizes the neurophysicians or neurosurgeons to operate. What I have read and I feel is less than 30 ml hematoma does not need surgery, and you treat them by surgery or by medical means. They have relatively equal and good results. Every hematoma more than 30 ml, especially 30 to 60 or 60 to 90 ml, long-term outcome is equal in terms of mortality and morbidity. Either you operate or you do not operate. Problem is that most of the neurophysicians, even if they have hematoma patient, like in our college, every patient's reference comes to neurosurgeon to do the intervention. We don't admit any hypertensive or ICH bleeds because we already have too much of neurosurgery patients. So what happens for probably medical legal reasons, they send reference to us. Now we have to convince the patient that, okay, if you want, we can operate. Probably the mortality, immediate mortality will be reduced, but patient will require a prolonged ICU care, and maybe he may remain dependent on others for care lifelong. So they then get confused. Patients attendant whether to, when initially they are under a lot of emotional pressure, they want, साहब ऑपरेट कर दीजिए, आप इतना बड़ा हेमेटोमा है, डॉक्टर साहब तो कह रहे हैं ऑपरेट किए बिना कुछ नहीं होगा. एक प्रॉब्लम, प्रैक्टिकल प्रॉब्लम आती है, and everybody has to face this and solve it at their own individual level. I personally am not in very much favor of removing hypertensive bleeds, even large size. I think we can go on to for the second presentation.
Yes, sir. Nice take-home message. Second presentation by, I think, Dr. Rajiv Ogura, please take over. Dr. Rajiv,
think,
please.
yeah. We'll invite. I just Dr. Arvind, can you just take over, please?
Yes.
Dr. Ramakant.
Sir, I invite our second this chairperson, Dr. Ramakant Yadav from CEFI. He is pro VC in CEFI Medical Institute and also the head department of neurology of Medical College CEFI.
Thank you, Dr.
Raman,
Kankane. So the next topic of today's webinar is acute ischemic stroke, the journey so far. And our speaker is Dr. Sanjay Kumar Saxena. Dr. Sanjay is a very renowned neurophysician of NCR. Presently, he is principal director and head of the department neurology Max Super Speciality Hospital and at Parparganj and Vaishali since last 2016. Previously, he was senior consultant in Bimans, New Delhi. He has worked in Fortis Hospital, Noida also. He has passed his MBBS MD from Aligarh Medical College and DM from GB Pant Hospital. Dr. Saxena has presented a lot of papers in various national and international journals. And his area of interest are the stroke demyelinating disorder, epilepsy, and movement disorder. So I invite Dr. Sanjay to start his presentation. Please.
Thank you. So I'll be sharing my screen now. I hope it's visible. Is it visible, the screen?
yes.
Oh, it's the last slide, which is don't be happy. This is just a technical error. So I'll go to the first slide. People are sometimes they're happy to see the last slide first. So thank you so much. And it's a kind of my special feeling for UP UK neuro scientists here to be presenting this interesting topic to all of you. And we have been living in a different world in Delhi NCR in the terms of the kind of facilities, the kind of patients we get here. And we are really able to do a lot of high-end work here. So I'll be sharing our experience here. And as has been very kindly introduced, I'm grateful to Dr. Arvind Kankane for giving this introduction. And Dr. Ramakant is a dear friend of mine. And he has been in touch with me for so many years. So we keep interacting at various platforms. So this is the team. And one of the special accreditations which we got from Indian Stroke Association and Quality Council of India. It was first time, just about 3 months back for the stroke only. So let's board the journey of fascinating journey of stroke, which has been really exciting, become so interesting in the last 20 years. So that is one area of the neurology which has taken neurology from the previously thought area branch of just a aspirin branch or B complex branch to area or level where we can do so many interventions and immediate results which we see after treating an acute stroke. They're really remarkable. So it started from the awareness, which has increased all across the various strata of the society, the clinicians, the physicians. And you would be surprised to know that about even 10 years back, people were not aware from our own colleagues in other departments of the practicing medicine that there is something called thrombolysis, or we can revert the deficit if the patient is treated within that time window. We have learned so many things about the stroke characteristics and behavior over the last 25 or 30 years, pathophysiology. And the most important thing which has happened is the advancement in the more reliable technology and the introduction of artificial intelligence to interpret these technological advancements and give us an idea about the newer options which are available, not only time-based, but now it's a tissue-based approach. So it is not the time window strict 3 hours or 4.5 hours. It is a tissue window which gives us an insight about the treatment which we have to plan. So it's a teamwork. It's a huge teamwork. Starting within the hospital, it requires a lot of teamwork. And so the key factor is reperfusion therapy for acute ischemic stroke. And selection of appropriate candidates for reperfusion. It demands a neurological evaluation and neuroimaging study. In addition, reperfusion study for acute stroke requires a system that coordinates pre-hospital emergency service, emergency medicine, the ER, stroke neurology, intensive care, intervention neurology, neuroradiology, neurosurgery to provide optimal initial care of the patients. So this is the stroke team, which ideally comprises of neurologists and then all the other members which are involved, right from the security person sitting at the emergency room to guide the patient. So the reason is to not to waste even a single moment to treat this. This is the stroke team consisting of so many relative departments. So it's a chain: detection, dispatch, delivery, door, data, decision, drug. That is what has to be coordinated at the hospital level and management level. We look at this, the global burden of stroke, it is really enormous. And you can see how many people they become disabled. And 116.4 million daily. That means disability adjusts life years are lost every after a stroke. And the incidence of stroke is now reducing in the younger population, so increasing in the younger population. So that is what has been depicted here in the global burden of stroke study. But in India, it's even worse. It is the second commonest cause of death in India, as we all know. And as you see here, one stroke happens every 40 seconds in India, and one stroke death every 4 minutes. So these is just the understatement. If you look at the volume of the people who suffer from stroke in India, in rural areas, far off areas, cannot count the number. It's a huge burden for the society, and these people, they may become or may have been becoming the disabled throughout their life. In India, unlike West, the hemorrhagic stroke is quite common. One of the reasons may be poor compliance with the antihypertensive drugs. If you are talking about hemorrhagic stroke in the hypertensives, so India is really challenging. We have inadequate availability of the facilities. As I told you, there. If we talk about the comprehensive stroke care centers, they are very little, and they are located only in the metropolitan cities. They are far away from the needy people who are living in the rural areas. So the main idea, what has happened in the last, say, 2 decades, is what changes we have brought about and what has happened over the therapeutic window. So as we all know, every minute a stroke destroys 1.5 million, 1.9 million neurons, 1.4 billion synapses, and 7.5 miles of myelinated fibers. Time is brain. However, recent trials suggest the equation is more complex, non-linear, and greater individual variability is now being selected and being found out. So these are the bottom lines: onset to door time, how soon a patient can reach to the hospital. Then once he reaches to the hospital, this is the responsibility of the place where we are working. How quickly we can intervene if that patient is eligible for the therapy, whether it is an IV thrombolysis or even mechanical thrombectomy. So this we have to reduce down. And we will see during subsequent slides how quickly we have been able to do that. It's just a habit which we have to change. So how to expand the therapeutic window? What are the new agents and new approaches? So over a decade, especially in the last 5 years, the individualization of acute stroke care has become complex. And as we are moving on, there is more and more complex concept evolving towards precision medicine. So the precision medicine is specific for that individual, like we see in oncology. A lot of specific, precise chemotherapeutic drugs and monoclonal antibodies have been developed. Similarly, in stroke patients, we have to be very precise in selecting our patients, especially more so after the therapeutic standard window has exceeded. And most of the important things which have taken place is the imaging guidelines. They have changed the whole game. They are the game changer. So time is still the brain, but with precision. So we can extend in if allowed by that individual's ability to adjust to the acute ischemia which would occur after a stroke. So if you talk about 1998, what was the treatment for stroke? Patient would have a stroke. CT was available. MRI was being made available in the country. It would pick up a stroke. If it is ischemic stroke, then patient would be admitted if required, treated with n number of options and drugs, but with none of them were effective. I remember the patient, the physicians used to give, or we were giving antiplatelet, aspirin or Percentin, and then came up. Even the anticoagulants were given blindly without any trials, and we obviously results were not satisfactory. Then came the standard, the main trial, NINS trial, the landmark trial, which proved that IV thrombolysis within 3 hours should be taken to the eligible patient with inclusion and exclusion criteria to be strictly followed. And it showed the significant improvement of the patient who received this therapy. And of course, that was a game changer for the stroke, acute ischemic stroke. Then after 10 years of this 3-hour window, it was extended to 4.5 hours by another landmark trial, ICAS-3, done across the Europe. And of late, it has been now standard line of treatment all across centers. So what decides the decision making, the therapeutic option deciding the option in these patients. So once a patient come to ER, the first challenge is to identify stroke. There's so many mimics, so there would be another topic if we talk about mimic. So if it is stroke mimic, it has to be tackled in a different way. If it turns out to be stroke clinically, then patient should be taken for either a CT scan, which is the most commonly used therapy, or if the time window is borderline, then even a hyperacute MRI, if available, would give us more information about the ischemic zone or the penumbra. So eligible patient would be given IV thrombolysis. If not eligible, then of course patient would be taken up for further studies. And the idea is to find out what are the patients, even those who present to the hospital beyond 4.5 hours, whether they are eligible for reperfusion or not. So ultimately, what has changed the game altogether in during that 4.5 hours window, beyond that is the thrombectomy, the endovascular mechanical thrombectomy, which I think I'll discuss. These are the few initial cases which we saw and we found. Oh, I think video is not showing. So these were the one of the initial cases which showed dramatic improvement after IV thrombolysis. This was about 20 years back. This was father of a cardiologist, and there was some time taken to get the consent. But since son was a cardiologist, he agreed for the thrombolysis, and he recovered within 24 hours. NIHS, the quantification of the weakness, it improved to almost 1. So that was the reason. He was the guy I think he's playing here. So he is having left hemiparesis, if you would see, and dysarthria with left facial palsy. So luckily he agreed and he had wonderful outcome. And this is, I think, the very next day. So I probably video is a little tardy, it's not showing. So he improved absolutely normal in the next 24 hours and he was discharged. A young male had, yes, again, this was a right-sided weakness. And he had, so you could see dysarthric right-sided hemiparesis. And this is after thrombolysis. You can see the day of discharge, 3 days after the discharge. Everything had improved and he was up and about, back to his normal self, and he is improving. So he had recurrent TIA, persistent right hemiparesis, which improved after IV thrombolysis. The initial few results which gave us a lot of confidence that yes, it actually works. It is not just there in the Western world. So that is where we started picking up and the concept changed overnight. So we were looking for now more patients who would be eligible for thrombolysis. So in the past 2 decades, that is what algorithm, 3 hours, then the ICAS-3 trial, which extended the window to 4.5 hours. Then 2015, we had another option with us, that is the mechanical thrombectomy, which were various trials, and in fact, AHA and ASA approved as a level 1 evidence for mechanical thrombectomy in the large vessel occlusion of the patient presented with LVO. And now it has gone beyond. So now it is beyond 4.5 hours IV TPA by certain trials. It has been showed wake up trial. The wake up trial was done to find out the patient who had stroke during their sleep. And since nobody is aware about the onset of the stroke, a special technique for MRI, not a special technique, but just a new concept of diffusion weighted image with flare images. There was a mismatch, hyperintensity not seen on flare. Then I think these patients would be considered for IV thrombolysis. That was possibly beyond 4.5 hours. And that window was extended up to 24 hours by a few more landmark trials on mechanical thrombectomy, DAWN, Diffuse 3. And now it's being practiced. I'll show you a few of the trials. And then extend I8 TNK trial, which showed patients should be given uh, that treatment within 6 hours or even beyond after doing certain imaging studies based on the CT scan. So imaging of of a stroke patient is very relevant. We should see parenchyma to identify stroke. 5, that is the vessel which carry the vessel, whether they're occluded, they're tandem lesion, there's a major vessel occlusion, or it's a small vessel occlusion. Perfusion, that means the new technique is now perfusion. So perfusion could be CT based or MR based. CT based is very handy, very quick, and we can study either multi-phase CT to look for even collaterals, or we do CT perfusion to look for penumbra. So that penumbra would decide the future line of treatment, and that is variable in most of the patient after the onset of the stroke beyond 4.5 hours. So that is what is seen typically. This is just a diagrammatic depiction, dead tissue, that is the infarcted area. And this is the penumbra, which is ischemic zone, which we are trying to salvage. This all exercise is based on this. So oligemic area, penumbra, and that is what happens. Onset of stroke within a minute, they report even up to 6 hours, it may hold on. So we should intervene within 6 hours. There is a possibility of reperfusing this penumbric zone, but then it keeps on expanding and of course becomes irreversible. So if we would have treated the patient, it would stay like this. If the treatment is delayed or patient is not eligible, it would lead to a bigger stroke and long-term disability. So that is what is one of the depiction of those vessels. So we should look for mismatch, the major vessel occlusion or thrombus, and again a major vessel occlusion for the endovascular technique. So patients who are eligible for endovascular treatment should have intracranial vascular studies. It's obviously you can't see vessels, so you can't comment on that. Performed during the initial imaging, but this should not delay the administration of IV thrombolysis. So that is very important. So what is the routine practice? The patient comes within 4.5 hours. We are suspecting a large vessel occlusion because clinical presentation of large high NIHS score or patient is having large deficit. Then IV TPA should be given, and after giving that TPA, it may be actualized, or if there's a large vessel occlusion, then we can use tenecteplase, which we are using now more often. And then patient should be taken for vessel imaging. If there is a large vessel occlusion, which is amenable to endovascular treatment, then we should take the patient up for thrombectomy. So in selected patients with large vessel occlusion in the anterior circulation, 6 to 24 hours after onset of acute ischemic stroke, CT or MRI perfusion or diffusion-rated MRI studies are recommended to assist in determining eligibility for mechanical thrombectomy, but only if other selection criteria for initial studies. So they were the initial criteria. Now it's being into practice now. In some patients with planning mechanical thrombectomy, collateral flow studies may be necessary for the precise process. In patients with wake-up stroke or in whom time of stroke onset is unclear, use of imaging to select patients for RTPA or tenecteplase should only be done with a clinical trial setting. That was an old saying of 2018, but now it has changed. It's being practiced. So let's see another case. A 73-year-old female came to ER with sudden onset of weakness of left side and gaze deviation. That means large stroke. She was hypertensive but non. Sir, NIHS score, which is the quantification of the deficit, was very high, almost severe, 21. And that is how she looked, very sick. We did a CT scan. There was no large, early signs of large evolving stroke. Aspect score was high. And this was the occlusion of right middle cerebral artery, M1 distal. She was treated with standard guidelines. It was 10 years back. So we were just evolving towards the mechanical thrombectomy and IVTP. Since she was there within 30 minutes, and we could give her IV thrombolysis, and then followed by mechanical thrombectomy. So that was the bridging therapy we call. And post-intervention, patient improved NIHS to 5 from 21. She was almost walking with mild support. So that was the occlusion, no dye going here in M1, and this is what was achieved after mechanical thrombectomy. So this is a lady at the time of discharge on 7th day, and she became a messenger for us for Stroke Day awareness program. So she led that program. So we were really very excited, and these are the few examples which really keep encouraging us in the clinical practice. A difficult case, 28-year-old male with no comorbidities, right-sided weakness with slurred speech at 12 noon, reached Max Hospital, Patpagan at 1 after 1 hour. BP, etc. was normal. He was dysarthric and H score was 12. He was treated with thrombolysis as there was no bleed, no major aspect score was high. So CT angio was also done, which revealed right vertebral artery thrombosis. Patient was thrombolized and shifted because of some technical reason to Max Hospital, Vaishali. But he's deteriorated rapidly, and his motor power also weakened. He had gross bulbar weakness. He aspirated and had to be put on ventilator. Echo was done, which showed global hypokinesia with 40% ejection fraction, and CT scan was repeated, which showed bilateral cerebellar and the left parietal infarct. TE was performed during the course of 7 8. This is what it was found: a large thrombus in the left ventricle. You see that it's about to just leave that caudate tendon and going to just exclude and block the opening of the aorta, aortic opening. So this would have been catastrophic. So luckily, CTBS surgeon was available there at that point of time. We discussed and he said, okay, I'm going to remove the thrombus overnight. So that was a very welcome decision he took. I have seen in my practice, this is probably the second case where we could do embolectomy from the cardiac origin and we could save that life, not only save the life, but it was found that he had more extensive thrombosis, later found to be, he was having one of the protein S deficiency syndrome and he was on he had to be put on anticoagulant. But after this stroke, he improved significantly and MRS improved to 1 after 3 months. So that is what a patient who would have died otherwise, had there been further embolization from the cardiac source or left ventricle, we saved a life and he was back to almost normal. So these are the motivating cases. So continuing with that about the imaging, now another important development which has taken place in the last couple of years is doing a perfusion study of MR based without giving a contrast. So this concept came up with a new sequencing which is called arterial spin labeling, and I think it's being practiced in some of the hospitals, maybe in Lucknow also, I'm not sure. So this imaging technology picks up penumbra without giving a contrast. So we use this, now been using this more often because it takes just 3 minutes or 4 minutes extra to get this sequence done, and we can pick up a viable brain tissue or the salvageable brain tissue penumbra. So few ESO guidelines also recommend the same practice which we practice here, and more clearly the quality of evidence is beyond 4.5 hours. Still they give, if the criteria based on tissue imaging and AI is found out. So if we talk about AHO guidelines, now these are very simple. Alteplase recommended patient can be treated within less than beyond 3 hours. This is a new addition. Otherwise, in US, FDA had not approved thrombolysis beyond 3 hours. So it has been now carried out, corrected. And now it can be beneficial patient with AS who awake with stroke, wake up stroke, and there's another change. And onset maybe more than 4.5 hours from the last known well or at baseline state, and who have diffusion MRI lesion smaller than 1/3 MC and no visible change on flare. So this is another addition or modification they have made. This is a practical change which they had to make. Reasonable to choose tenecteplase over IV alteplase in patients without contraindication for IVT who are eligible for endovascular treatment. In fact, some of the trials have shown that tenecteplase may be more beneficial in producing reperfusion in the large vessel occlusion for the patients who are eligible for mechanical thrombectomy. So for the bridging therapy, now we are giving tenecteplase more often because of ease of administration. It's just a bolus injection and possibly more effective than alteplase, as some of the trials which compared the two agents have shown. So that is the bridging therapy which I was talking about. It is one of the guidelines in US as well. Mechanical thrombectomy in patient with pre-stroke MRI is 1, causative occlusion of IC or M1, age more than 18 years, NIHS more than 6. That means lesser infarcted core. And in that patient, the door to groin puncture within 6 hours of symptoms should be considered. That was initial. But in certain patients with better technology used for identification of the penumbra, like in down or diffuse trial, MT should be considered beyond 16 hours and even up to 24 hours. So some of the trials, diffuse 3, have shown that even IV thrombolysis can be shown. So what is the time window? Is it still 3 hours or 4.5 hours or 6 hours, whatever? So it is the salvageability of brain tissue, largely depending on the degree of collateral perfusion of the ischemic territory. That is individual based. So that is why it's again a precision medicine. Every individual would have different ability to salvage the brain tissue or the ischemic zone, and that is where the technology has been helping us immensely, and we can identify more and more patients who have that viable ischemic penumbra for a longer duration time, they benefit not only, if eligible for mechanical thrombectomy, even if they are not eligible for mechanical thrombectomy because of any reason, because they may not be having a M2 or M3 or distal occlusion, then IV thrombolysis, carefully chosen in selected patients, would be beneficial, which has been shown in the recent trials, even up to 24 hours. So these are the three conditions. Scenario A, this is the guideline based, not eligible for. What happens? 8 a.m. person gets a stroke, arrives at 4 p.m. Symptom was discovered, and 4:30 arrived to ED or emergency department, routine care. But of course, since it is cost what 8.5 hours, I think is not the candidate for thrombolysis. But in the recent area, if we are able to do the advanced technology AI based, then if he is eligible, then we can consider. So this was maybe about 3 years back. In the second scenario, if it is detected at 3 p.m., he brought to hospital at 4 p.m., then I think we should do an imaging. If he's eligible for TPA or Actelize or Tenecteplase, then we should give that. So he's one of the candidates. Now here is a little catch. Patient was last known well at about 8 a.m. Seen by somebody at 1:30 that he has suffered or she has suffered a stroke at 1:30, brought to hospital. So the time is not known at what time between 8 and 1:30 he suffered symptom, onset of the symptom. In that case, there are so many recommendations which I am talking about. We should take help of the advanced technology and find whether this individual has got that natural capacity or the compensatory mechanism which are active, and he may still have a viable penumbra. So we should not deprive him of thrombolysis or mechanical thrombectomy in that situation. So less than 6 hours, no doubt, endovascular intervention will help. If patient was eligible for IVT, then even that should have been given as a bridging therapy. And beyond 24 hours, also various trials have shown the benefit of mechanical thrombectomy. There are various trials which have been done. Let's see a very interesting case. A 45-year-old practicing psychiatrist in nearby town from Delhi had right hemiparesis at around 10 p.m. Rushed to a local hospital. CT head did not show any hemorrhage. They was put on dual antiplatelets. Next day, it's 5 a.m., not p.m. Motor weakness progressed along with motor aphasia, brought here at around 10 a.m. So he came to hospital about almost 12 hours. NIHS was 14 and tissue-based imaging was performed. So this is the technique I was talking about. This is the ASL sequence. So it is showing an area of large penumbra with diffusion weighted film, unfortunately was not available. There was a small core of infarction and this was a large penumbra. It's well salvageable. We went ahead with mechanical because he came at 12 hours of the onset of symptom. It showed T occlusion of the internal carotid of the middle distal ICA. And you see there was no flow seen, and this was a thrombus which was detected on the studies, DSA, and beyond the thrombus there was vessels were patent. So he was a candidate for removing this thrombus, but all the vessels distant were patent. So this is I think you can see small dots, stent retriever is being placed, and then after the removal of the thrombus, you can see the circulation was restored, and these were the few hard thrombi which were taken out. More of white, high fibrin. So mechanical thrombectomy was performed at 13.5 hours of last known well, with NHS improving to 7 within 48 hours. After a month, he was independent with modified ranking scale of 1. And after 2 months, he joined back his roaring practice once again. So it's a God's gift to him that he came back to his practice after having suffered a major M1 occlusion. This is the 84-year-old guy, 84, just look at the age. He came with acute stroke, and this was cervical ICA getting occluded here on the left side. He was walked up. This was the DSA done immediately, negotiated, and angioplasty was done. But to our surprise, even there was another block at the T. So IT distal ICA or at the bifurcation. So he had ICA occlusion, which was manipulated only with angioplasty. Catheter could be could be taken distal, and you found that there was a occlusion here. So no uh, uh, blood flowing beyond that. Imaging did show there was a mismatch. This is a poor quality image. Thrombi were taken out, and you see all the perfusion was restored. And this gentleman, in spite of being 84 years old, had a fantastic improvement, and after 2 months, his MRS was just 1. He was independent for all the routine activities of his. So, mechanical thrombectomy has now come of the age. It is one of the standard guidelines, but one would be thinking just if there's a large vessel occlusion, why not just go for mechanical thrombectomy? But there are so many advantages. If the patient is come in the window of, say, 4.5 hours, IV thrombolysis has a lot of advantages, which can aid many patients who have M1 occlusion or even ICA. We have seen that the thrombi, it breaks up the thrombus, and the perfusion is restored even with IV thrombolysis while doing DSA. But then it makes it more amenable to thrombectomy. It becomes easier to take out the thrombus. And if there was a distal thrombus to that major thrombus, that would also be getting lysed with this IV. So these are the advantages. That is why it's still standard practice to give IV thrombolysis within that window if the patient is eligible, followed by mechanical thrombectomy. So there are various trials which I've already discussed about. Most of them, they showed significant improvement at the 3 months from that initial presentation. 90-day outcome were excellent. Extend IA, Revascat with recent trials. So they all have said case up to 24 hours or 16 hours or beyond 6 hours is going to be effective. And with or without delta and acute stroke is a recent direct MT trial. Dawn trial had already, I've told you, has shown improvement in of at least 2 reduction of 2 points in the MRS the 3 months. So we have had quite a few patients in the last few years, just 1 year, 1.5 years data, and 50% were beyond 60 years. Ischemic. So we also had higher hemorrhagic stroke in our patients, about 24%. And out of the total patient, 26% patient could be thrombolized who were eligible for IV thrombolysis. And further, say about 4% patient with large vessel occlusion could be considered for thrombectomy. Thrombectomy, another limitation, though there are definite advantages, that it is still expensive, and many people, they can't afford this modality of treatment. So it has shown very good results. Most of the patients, they had M1, but many patients had tandem or IC occlusion, posterior circulation or basilar, only very few. And outcomes were largely great in most of these patients. But of course, we have had a couple of mortalities also. Recanalization was achieved in majority of the patients, and complication rate was high except for odd bad result. So these patients had a 2 to NIH score varied from 2 to 21 of all those patients. Average NIHs were 9. And the most important thing which has evolved over the period of time is reducing door to natal time or door to puncture time. So that is the single most important factor which can be changed at our end. That is what we've been trying to do. And it is now mostly less than 30 minutes. And there have been few patients who came with CT scan and we could thrombolize within 5 minutes. So 10 minutes it would take, or 20 minutes to get a CT scan done and make the patient eligible or ineligible for the thrombolysis. So our patients had a good response to 60%. Patients, they had recovery to 0 to 1 scale at 3 months. And large vessel occlusion patient who were judicially selected, they had good outcome, reduction of 2 points in 75% of the patients. To end on a high note, just the last patient, which is very close to our heart once again. A 29-year-old male developed sudden onset numbness of left angle of mouth and left hand grip. Went to a nearby hospital. He was at Rishikesh or Haridwar at that point of time. In afternoon, he developed left hemiplegia. CT scan was done and found to be normal. Then he was brought to Max Hospital at night, maybe about 9-10 hours. BP was okay, and he had power 0 by 5. And as per the records, you can see on the. So he had this diffusion weighted images done, which is showing patchy infarction in the territory of right middle cerebral artery, even the deeper branches, and flare did not show. So he was having the diffusion and flare mismatch, candidate with potentially salvageable penumbra. MR angio was done, which revealed no ICA visible. So there was an occlusion of ICA in the neck. Here you can also see there is on the left side there is ICA, right side there is no ICA occlusion in the neck. So we did an ASL here again. So non-contrast, it took just 3 or 4 minutes extra. We found a large area of hypoperfusion. This is hypoperfusion, and you look at diffusion. So this is the core, and this is the penumbra. Even without a contrast, you could see the polygamic zone in the right cerebral hemisphere. So that is what it is. You see here, the large penumbra, vessel was occluding, no ICA seen. So these were the candidate for mechanical thrombectomy. We did not go for IV thrombolysis because it was more than 10 hours. So he was taken up, and next early morning at 3 o'clock, he underwent and look at the CT scan, just small hypodensity after 48 hours, and he's improved power from 0.5 to 3.5 within 24 hours, and it became 2 after 2 weeks and improved to 0. So he totally recovered. So that is the perfect case for a precision medicine for that individual. So had we not done all these exercises, thinking that it's now 10 hours, what to do? Nothing can be done. But then we went ahead, we did this procedure, and we found that patient, he responded so well. So it's been mix and match for us. Thank you so much for the sharing. My take-home message would be, now stroke has come of age. It is a different disease than what we used to think pre 1996, and now we are expanding our windows. And there is a possibility the patient who suffered a stroke even 6 hours or 10 hours back may become eligible for uh, treatment, whether it is mechanical or thrombotic IV thrombolysis. Thank you so much.
Thank you, Dr. Saxena, for a very informative lecture. And I think you are doing a lot of thrombolysis, and patients are reaching in time in your hospital. We are also treating patients, but usually they don't come in within that window period. So thrombolysis is not possible in our center. So I think this forum is open for questions. If anybody want to ask, Dr. Saxena will be happy to share his experiences regarding treatment of the stroke.
Yeah, please.
Sir, you have nicely described about journey of development of treatment of stroke from masterly inactivity to thrombolysis to mechanical thrombectomy and time-based to tissue-based approach. And you are doing very good job, and you have shown a lot of patient who has been improved by your treatment. But treatment is still out of reach of common person. I have seen at my center the majority of patients not affording even thrombolysis, cost of thrombolysis. So it is long way to go to, so that treatment is precision-based medicine is available for all of us, all and each and every individual. So I think it is long way to go.
Yes, yes. So that is how it's going to be. So government has to intervene, and they have to somehow cover the cost, make it available at across all the major, at least cities or towns where you have medical college or presence of neurologists or the team of neurologist, neurosurgeon, and expertise. Now more of the more neurologists, they're going into intervention. That's a very welcome
Yes,
change. So you can
definitely.
see so much of police. So that's the game
Yes,
changer going to change tremendously in the next 3-4 years. This is what I'm sure. It is going to go to places in India at the towns or areas where even IV thrombolysis is not available. But now I think we will have awareness and the kind of experiences which we have had in our centers and other cities. That's going to expand tremendously. So, a lot of potential.
Our one viewer, Naresh Krishnani, has asked if DWMRA is normal, but patient has signs of a stroke. Do we still give TPA? I think yes.
So that depends on certain conditions. So let me tell you when we should give and when we should not give. Suppose a patient has come with recurrent TIA lasting for 30 minutes, 40 minutes within a day in crescendo. And they may not be diffusion rated, may not see an MRI with the hyperintensity in those patients. But if there is on the left hemispheric young patient, we can thrombolyze. It should not give any complication, but patients have. So I showed you one young chap who had that recurrent TIA, one of the initial slides. He improved. He just had recurrent TIAs, but those TIAs had to be treated. And rather than giving anti-coagulant, which was a practice initially, we should consider if they can be given. And there was a vessel with disease also, which is found in that patient. The patient who should not be given TI, so there are some stroke mimics. We have to identify those mimics, whether that's an ischemic hemiparesis or something else. Recently, we had a problem with a patient who had an acute presentation of right-sided hemiparesis, but when we examined, he had left-sided weakness also. So in that bargain MRI, brain had been done in the ER by our hyperactive ER team. There was no infarct. But I went and examined, it was a quadriparesis, and that lady had a lesion in the spinal cord. There was a small bleed in the cord. So that was probably related to some trauma. So that is where we should look out. Clinical examination will still hold the key and look for mimics of stroke. If TIA is ischemic, that improves on its own within 30-40 minutes or within 1 hour. And even if the diffusion rate doesn't show any hyperintensity or infarct, we should thrombolize.
Thank you, sir. Thank you very much. Sir, thank you very much to both of speakers, Dr. Ananda and Dr. Saxena, sir, for delivering such a nice and elaborative talk on their respective topics. I request our chairperson, I think Dr. Oja has left this talk because of some urgent work. We have Dr. Ramakant sir, who is one of the chairperson. I request him to please give some comment on this today's CME.
First, I thank Dr. Kankane for your initiative to start these webinars, and it will be a great effort for all of the neurophysician and surgeon to get united and also gain knowledge, recent knowledge also. So, and both the speakers are very good. A young chap, Dr. Ananda Gupta, has delivered his lecture very well, and sir is a great neurophysician. Everybody know him, and he has elaborated his journey from very beginning to recent what we are doing in the stroke patient. So I thank both of you, sir, and I think this type of the webinar will continue. And
sir, we are going to continue it as on monthly basis. We'll continue it on every month, second Saturday from 7 to 8 p.m.
That is great.
Wonderful.
Sir, we have e-certificates. Please do the honor of both of speakers by e-certificate. Mohit, please share e-certificates.
That's a lovely gesture.
Sir, we have e-certificate. The physical certificate in physical form will be delivered during the annual conference.
Oh, wonderful.
Normal ceremony of annual conference, we will just bestow you with the physical certificate.
Great.
Right now, we are meeting virtually, so we have virtual certificates.
Yes, that is practical thing to do. Really nice. Thank you.
Mohit, please share certificate. Actually, there was some problem with my laptop at 11th hour, so I couldn't able to join at start of this meeting.
Right. We were told about that, but that can happen with anyone.
So, Mohit, please share. Sir, this meeting is being broadcasted at another one. This is the certificate of Dr. Ananda Gupta.
Thank you, sir. It was indeed a great pleasure. Yeah.
Thank you.
Looking forward.
Thank you for delivering such a nice elaborative lecture on intracerebral hemorrhage.
Yeah.
Good job done, Anand.
Very nice.
Thank you, sir. Thank you. Yes.
Please share another certificate, Mohit. So
thank you.
Sir,
grateful.
Thank you, sir. Thank you very much for such a nice and elaborative talk. Thank you, both of speakers. And I also thank you, both of chairpersons, for remaining with us and sharing their view. I also sincerely thank all the viewers who remained with us throughout the lecture. Thank you. Thank you for attending, everyone.
Thank you.
We'll continue this activity in future also. Sir, your certificate will be given to you in annual conference.
So I'll have to be
Please
there.
stay with us in the annual conference also.
I will definitely would love to be there. I'll come
So
there.
that will increase the attendance of the annual conference itself.
Very smart thought. That is the
Thank you,
human intelligence. We talk about artificial, but the human intelligence always score over AI.
And Dr. Arvind is very well versed with it.
Yes.
In joining people.
Thank you.